I told you that today's our guest is Dr. Deepthi Krishnamoorthy. She is a MD Homeopathic and PG diploma in ACH, Greece. She is an eminent homeopathic practitioner practicing classical homeopathy in rural India. From past 11 years, she is serving the rural area of North Karnataka, India. For now a few days, recently all from Karnataka. That is great. Many efficient doctors are from there. We are very much happy to welcome you because you are doing wonderful job. She has a master's degree, MD in homeopathy from a recognized health university in Karnataka. She has acquired a PG diploma degree in classical homeopathy from International Academy of Classical Homeopathy. Alonos, Greece. I don't know whether my pronunciation is right. She is able and experienced in treating several cases like hypothyroidism, PCOD, and several other women-related diseases. She is the co-founder and co-director of Dr. Murthy's Classical Homeopathy Hospital, which has its own patients set up. And it is a rare its kind with multiple facilities like well-equipped consultation chambers, a huge pharmacy of homeopathic medicines, minor OT, general wards, special wards, and a waiting lounge. Its branches are located in Shahabad Taluk of Wadhur district and Gulbarga city of North Karnataka. Today, she is dealing a subject. We know that homeopathic management of hypothyroidism. Because most of the patients, I think that many patients of women coming with this type of complaints. But normally we will think that some other heart disease or anything like that. Sometimes it may be a case of hypothyroidism. That is the thing. So let us welcome Dr. Deepthi Anand. And for the next 45 minutes, you can deliver your speech, and after that there will be a question hour. So you are most welcome, Doctor. Thank you, Doctor, your presence. Okay.
Thank you so much, sir. Thank you so much. Namaste. I'm greatly honored to be presenting on this platform because as I've seen, there are so many senior homeopathic doctors, and I'm greatly humbled because I'm so small, so young, and my experience is really very less when compared to people who are there here. So let us start the presentation. I am presenting a series of cases on hypothyroidism, where we can see that homeopathy can bring great changes.
Doctor, you can we can see your slides and everything.
Hope all of you are able to see the slides.
Yeah. We can see it.
Oh, okay. So
okay,
first of all, okay. Thank you, sir. First of all, we see the objectives of learning, which are to understand the clinical picture of hypothyroidism, first of all. Then only when we understand the clinical picture, then only we can know the pathology, and we can be better clinicians, and we can give good remedies. Next is to understand the efficiency of homeopathic remedies in the treatment of hypothyroidism. And finally, here there is a special topic, like to understand the various types of classical homeopathic prescriptions in the treatment of hypothyroidism. So first of all, I know there are all senior homeopaths, and I need not repeat all this. But even then, just to recollect what we have learned, I've put on this slide. We'll just recollect the anatomy and histology of the thyroid gland. The thyroid is an endocrine gland situated in the anterior part of the neck. It normally weighs around 15 to 20 milligrams in adults. And as we all know, there are two lobes, right and left, which are connected by the isthmus. And it is supplied by superior and inferior thyroid arteries. Now, the next point is quite important because there are follicles which are filled with colloid. And this colloid is quite important because this is where the thyroglobulins are present. And this colloid contains thyroglobulins in which thyroid hormones are present. Okay, about 20 to 40 follicles are grouped to form a lobule. Lobules in turn become lobes. Thyroid also contains C cells that secretes thyrocalcitonin, which participate in the calcium metabolism.
അത് നേരത്തെ ഉള്ളത്, പക്ഷെ ഇത് പുതിയതായിട്ടൊന്ന്.
ഹലോ ഡിസ്റ്റർബൻസ്, ഹലോ ഡിസ്റ്റർബൻസ്.
Dr. Hubert, please.
Shall I continue?
Okay, you can. Okay, but Dr. Hubert's sound is echoing.
Okay. I lost it. Okay. Thank you. Okay.
Okay, we'll continue. Now we'll know something about synthesis and secretion of thyroid hormones. See, basically, thyroid gland secretes two hormones. One is tetraiodothyronin, which is also called thyroxine or T4. And the second one is T3 or triiodothyronin. Okay. And as we know, thyroid hormones are basically dependent on the iodine consumption and iodine absorption from the gut. So after uptake, I'm not going into very deep details because it's just brush up. After uptake, iodine is oxidized by the enzyme thyroperoxidase. This is important to know. Followed by iodination of tyrosine. Tyrosine is a amino acid in the thyroglobulin. Tyrosine is an amino acid. So the iodine is oxidized by thyroperoxidase, which is followed by iodination of tyrosine. Monoiodotyrosine and diiodotyrosine are coupled later. The next step is monoiodotyrosine and diiodotyrosine are formed, which are coupled in varying proportions. That is, monoiodo is combined with diiodo to form T3, or two diiodotyrosines are combined to form T4. That way. Then thyroglobulin is then processed in lysosomes to release T3, T4 into circulation. The thyroid gland contains enough stored hormones to maintain a euthyroid state for at least 6 to 8 weeks. Hope everything is clear till now. We'll continue. The regulation. As we all know, thyroid hormones are secreted under the influence of trophic hormones. Under the influence of thyroid stimulating hormone, which is a hormone from the anterior pituitary. And this in turn is stimulated from the hypothalamus, where the hormone by the hormone called thyrotropin releasing hormone, that is also called TRH. So first of all, hypothalamus should secrete TRH, which will stimulate the anterior pituitary to secrete TSH. And this TSH will cause the secretion of thyroid hormones from the thyroid gland. That is, TSH will moderate, or it will stimulate all the steps, whatever I told you in the previous slide, and it will help in the release of thyroid hormones. And also, we have to remember one point here. T3 is the most active form and it is very unstable. So T4, most of the hormone is T4, and when required, T4 is converted to T3. Okay, by deiodinization. As we can see, T4 is secreted directly by thyroid, whereas 80% of T3, which is active, is generated by monodeiodination. Monodeiodination, that is, one iodine is removed of T4. Okay, and TSH and TRH, they again act by negative feedback. That is, when thyroid hormones are in good quantity in circulation, TSH and TRH are inhibited by negative feedback. Next, functions. Increase cellular metabolic activity. So basically, thyroid hormones are required by all the cells and all the cells of the body, because thyroid hormones increase the cellular metabolic activity. That is, it will increase the number of mitochondria in the cells, and it will increase the energy production, and thereby it will increase metabolic activity. So once the metabolic activity is more, all these functions of the cell is increased. That is, the functions are facilitated. The rate of functions become more. The net result is generalized increase in functional activity throughout the body. Not only single cell, all the cells. Okay, so BMR is increased, basal metabolic rate is increased, body weight is reduced. Once there is increased metabolic activity, definitely there is reduction in body weight. Then effect of thyroid hormone is manifest mainly in growing children. This is very important because it affects the maturity of bones and closure of epiphyseal plates. So here we have remember that if in cases of hyperthyroidism in young children, there may be maturity of bones early age. That is, say for example, a 10-year-old has hyperthyroidism. His bone weight may be of 13 or 14 years, or bone maturity may be of. And epiphyseal plates will close early, so that finally the final result is short stature, because the child will not grow beyond it, because there is closure of epiphyseal plates. So of course normal quantity is required, less or more, both will have a bad effect. The next, an important effect of thyroid hormone is to promote growth and development of brain. This is also very important. That is why nowadays, once the lady is conceived, once she comes to know that she is pregnant, the first test which is to be done is TSH and hemoglobin, because her TSH, her thyroid levels are very important for the development of brain of fetus, because till 11 weeks, the fetal thyroid will not work. So only after 11 weeks of pregnancy, fetal thyroid will work. Till then, maternal thyroid only is giving the hormones to the fetus. So TSH of pregnant ladies is very important to know. Next, that is because it causes development of brain during fetal life and first few years of postnatal life. It also stimulates carbohydrate metabolism. That is, it causes glucogenesis, neoglucogenesis, and increased insulin secretion, and also effects of insulin on carbohydrate metabolism. We all know the effects of insulin on carbohydrate metabolism. That is, insulin causes the uptake of glucose by the cells, and also it causes conversion of excessive glucose to glycogen and store it in the liver. So this is also under the influence of thyroid hormones. Okay, it also causes mobilization of lipids from fat tissue, and it causes the decrease of the concentration of cholesterol, phospholipids, and triglycerides in plasma. Thyroid has these functions. Overall, thyroid hormones cause the increase in all the body functions. That is the effect of thyroid hormone on all the body, all the parts of the body. So now we'll come to hypothyroidism. Hypothyroidism is a condition resulting from lack of effects of thyroid hormone on body tissues. See, I told you the effects. What are the effects of thyroid hormone on body tissues? So hypothyroidism is when there is less thyroid hormones, causing the lack of effects of thyroid hormones on body. Hypothyroidism is mainly of two types. One is primary or peripheral hypothyroidism, where thyroid gland is at fault. Okay, that is, hypothalamus and pituitary are working well, but thyroid gland is not working properly. There are various reasons for that. We'll take up later. Next is secondary or central hypothyroidism, where hypothalamo-pituitary axis is at fault. That is, either hypothalamus is not secreting enough TRH, or anterior pituitary is not secreting enough TSH. So there is not enough stimulation for the thyroid gland to secrete thyroid hormones. Okay, so this is secondary or central hypothyroidism. Just because hypothalamus and pituitary are involved, it is called central hypothyroidism. And the primary hypothyroidism, because the gland is involved, it is called peripheral hypothyroidism. Okay. Next, causes. So what are the major causes of hypothyroidism? Central hypothyroidism, as we all know, it can be either congenital or acquired. Congenital is in case of pituitary or hypothalamus problem, maybe there is some congenital problem. Such things can be happening. Or acquired. Acquired may be again when there is pan-hypopituitarism, as we call, like all the antideprecatory hormones are less. There is stunted growth, mixed edema, everything. Next is next primary hypothyroidism. We will see the classification. Primary hypothyroidism with goiter. Goiter, one of the major causes for goiter is iodine deficiency. But now, as the national program of iodization of salt is going on, like it's been a very long time. So since the salt is iodized, endemic goiter or whatever we say iodine deficiency hypothyroidism is greatly reduced because of iodized salt. Okay. Next is hypothyroidism with atrophic gland. Maybe the gland is at fault. That is what, as I told you, that is peripheral hypothyroidism, where even though TRH and TSH are normal, the gland is not able to reciprocate to the hormones because there is atrophy of glands. Next is transient, which may be post-parturition or which may be due to resistance of thyroid hormones. This is transient primary hypothyroidism. So next. So what are the clinical features? As I told you, when there is lack of thyroid hormones, there is reduced metabolic rate. Usually, the symptoms of hypothyroidism, they gradually develop over a great period of time. So that is why patient will, when the diagnosis is made, it is quite late because symptoms develop very gradually. And also you have to remember one point here, because thyroid gland stores hormones which is enough for almost 6 to 8 weeks. So that also matters because for the thyroid hormone to get empty, it takes 6 to 8 weeks. After that, symptoms should develop. So till we diagnose, it is quite late sometimes. Next, skin is pale and cool. There is reduction of sweat, of course, because the cells of the sweat glands, the metabolic rate is reduced. Reduction in sweat and sebaceous secretion. It causes dryness and coarseness of the skin. Okay, skin becomes scaly. There is capillary fragility, which causes easy bruisability. That is, wherever there is a small hurt, also there is bruise. Then scalp and body hair become dry and brittle, and they tend to fall because there is decreased metabolic activity. Decreased function. There is hoarseness of voice. Hoarseness of voice is because of the deposition of glycosaminoglycans in the larynx and vocal cords, because this decreased thyroid hormones cause the deposition of glycosaminoglycans in the tissues. Okay, then cardiovascular involvement. It includes this decreased cardiac output, of course, again, because there is less BMR, and also narrowing of pulse pressure. Pulse pressure is decreased, and there is increased systemic vascular resistance because there is, what is that? There is resistance for blood flow because of vasoconstriction, as I tell you next point. That is why there is hypertension, and there is cold intolerance due to diminished blood supply and vasoconstriction. There is weight gain, modest weight gain, despite reduced appetite. Even though the patient is not eating, the patient is gaining weight. And that is the main symptom actually. To diagnose hypothyroidism, one of the main symptoms is weight gain. That is, a patient says, I'm gaining weight invariably from past 6 months, even though I'm exercising, even though I'm having less food, I am gaining weight. Maybe in past 6 months, I've gained around 10 kgs. There is no cause for that at all. I was very thin. Now I'm gaining weight. And this is the main symptom. And hair fall, as I told you. Hair fall and weight gain. These are the main symptoms patients come to us when we first we check for thyroid. Okay. And appetite is reduced. And also there is constipation. Constipation because of reduced gut peristalsis. Again, because there is decreased metabolic rate, the cells are lax. They have gone to lethargy. They have become lethargic without thyroid hormone. That is why there is reduced gut peristalsis. So now we'll jump to clinical cases. Here I'm discussing 5 cases which are based on different types of prescriptions, which I'll explain later. Okay, the first case is a patient named CH. aged around 16 years, came to the OPD with the complaints of swelling in the anterior part of the neck since 9 months. Her TSH was 85.6. The normal TSH should be around 4.5 to 5.5 micro international units per ml. But her TSH was 85.6. Menstrual history. Generally, menstrual history is disturbed in hypothyroidism, but she is quite engaged, or maybe usually, but it is not in all cases. So in her case, menstrual history was regular cycle, regular flow, moderate flow, no painful menses, no white discharge per vagina. Personal history, she was thirstless, chilly, desire sweets 3+, boiled eggs 2+, salt 1+, milk 1+. Perspiration and palms and soles, sleep position left side. This is her thyroid report. See, as you can see, it is dated in 2016. The TSH level is 85.6. Sorry, I made a mistake. It is not 4.5 to 5.5. The normal is 0.3 to 5.5 micro international units per ml. So this is the repertory sheet. We repertorized. We took these symptoms for repertorization. That is external throat swelling, thyroid gland, generalities, hypothyroidism, desire sweets, 3+, and soft boiled eggs 2+. She sleeps on left side, because these were the quality of symptoms which we could consider for the case, because her menstrual history is normal and others are confirmatory symptoms. So here this is Vittel's compass, which shows calcarea carb. So we had given her calcarea carb on 31st July 2016, 200 centesimal potency BD for 3 days. Okay. Next is in August when she came, she felt better with her symptoms, like she felt more active, she was less sleepy. All those thyroid symptoms were there, which she felt better, and those are common symptoms, that are common symptoms to the disease. That is why it is not considered for repertorization. Calcarea carb 200 TAD 5 days was given. Again, when we checked in November, she came in July. When we checked in November, it was 12.2, which reduced to 12.2, the TSH. In again July, after 1 year, it became 4.8. I'll show you the reports. See, you can see here, 25th October, it is that she came on 11th November. She had got her test done on 25th October, which showed 12.4. And again, when she came in June, she came in July. She had done it in June, she came in July. This is 4.8. You can see the reports. This is the first case. Next is, see, as we can see, I'll discuss the types of prescription later. This is the second case. A patient named EVV, aged around 31 years, came with the following presenting complaints. She has pain in the cervical region since 5 years, aggravation winter, aggravation night, ambulation lying down. Pain started first on the left side and then came to right side. Painful cramps of muscles was there. There is increased hair fall. Okay. Menstrual history. Cycles were regular, flow moderate, no painful menses. And she had 3 kids, all normal delivery, full-term normal deliveries. Patient was recently detected with increased TSH while screening. General, see, people nowadays, people are quite aware. Educated people, it's like before coming to in cities especially, before coming to the hospital itself, they have reports. They know there may be some problem. They check for, they themselves check for their sugars, they check for their blood, that is blood counts, hemoglobin. They check for their thyroid, because Google is giving a lot of information to people. So just while she thought maybe she's not well, and she checked for herself, it was 11.02. Okay. Personal history, thermal chilly, desire sweets, food aversion, milk 2+, aggravation sour 2+. Nails were brittle. Patient is anxious about health. She's like, it's only 11. Even though when we said 11 is not an alarming increase, even then she was very much worried. So you can see it's 11.2. So these were the symptoms which we considered. Back pain, cervical region, night, first left, then right, hair falling, weather windy, she's anxious about health, cramping pain in the muscles. It was quite often. And sweet desire 3+, brittle nails 1+, and milk aversion. These are the symptoms considered. As you can see, there is calcarea phos. But based on her other symptoms, like some confirmatory symptoms, we gave her calcarea carb. Again, 12 potency was repeated 3 times a day for 7 days. Then she had after first prescription, after a month, she felt better with the cervical pain, and the cramps also were better. Same way you can see the follow-up. Then TSH was 4.2 in February. Then after that, she had an acute. She had fever, and there was thirst, increase of small quantity of water during fever. She had again anxiety about health. Based on the causes and based on her acute symptoms, acute prescription of arsenicum album 201 dose was given. After that, she felt better with her acute. Later again, we checked her thyroid in July, which was 3.32. So this, you can see the reports. Next, this patient named SK, 32 years, came to the OPD with the following presenting complaints. He's a male patient, and the incidence of hypothyroidism is more in females when compared to males. Here is a case of male patient. He had pain in the left sole since 4 months, which was aggravated in the morning, aggravated on exposure to cold. He had pain in the wrist joints in 6 months, more on left side, aggravation morning, amelioration hot application, left then right. There is distension of abdomen, bleeding gums, on and off. Past history we considered because there was a history of wart removal and repeated styes. And he also had acute fissure in ano, which for which he had taken Ayurvedic treatment. And he was recently detected with hypothyroidism when TSH was 50.39. Okay. Family history, because that was also positive. Mother was hypothyroid and hypertensive and diabetic. Father was hypertensive, diabetic, and he was suffering from renal dysfunction. Okay. Personal history: thirstless, chilly. He is disturbed. His sleep is disturbed because he is anxious about his health. Food: sweet desire 2+, ghee 2+, ice creams 2+. Perspiration more on face and neck, non-offensive. Sleep position left side. Patient is anxious and restless, shouts and throws things away when angered. This we have to keep in mind. Okay, so you can see it is 50.39. He was a dancer basically, this patient, and he had more of feminism. That is, he was more feministic. He was not masculine. He had that lean body type. Even his speaking, everything was more feministic. Okay, his appearance. These are the symptoms which were considered. Hypothyroidism, pain, wrist morning, warm application ameliorates, bleeding gums, left then right, warts suppressed, cervical region perspiration, aggravation from cold, then sleep position left side. So here we can see sulfur, but we prescribed him staphysagria because of his mental symptoms. As I told you, he gets irritated and he throws things away, and he does this only when he's alone. He does not do it in front of people. In front of people, he'll suppress his anger. And that is why, and he also had history of size, history of warts. So all these will count. So we had given him staphysagria. The first prescription was staphysagria 30 BD for a day, 30 centesimal. He felt better in the pain in wrist and sole, and distension of abdomen was also better. he had an abscess over the right nipple, which was an old complaint. Okay, he had it earlier. I told you he has more of female kind of problems with salivation during sleep. So for that acute complaint, we gave him Merck, but later he started feeling better with Merck only, and TSH also reduced from 50 to 17 with Merck. So we continued with Merck only. Okay. Then urticarial rashes all over the body. As we know, when the deeper problem is getting better, he had skin problems. So urticarial rashes. After that, in October, his TSH came down to 11.3. You can see here. After that, maybe patient was better, so he did not come for the next follow-up, and he did not get the this one. He was under treatment then. It is in 2000 way back in 2018. After that, no reports because he didn't come back. This is case number 3. The next is case number 4. Patient named AS, aged around 43 years, came for treatment of hypothyroidism. As she was a known case of hypothyroidism since 7 years, she was on thyroxine. Earlier cases, they were not on any hormones. Okay. This case she already knew, and she was on 125 micrograms OD early morning every day. Even with hormonal treatment, her TSH was 12. So she also complained of pain in calf region, alternating sites observation night. She had distension of abdomen, cycles early. Usually in hypothyroidism, it is quite common to have early cycles, 22 to 25 days. Flow moderate, dark, clotted, painful, menses, amelioration, flow. No abnormal white discharge. She had two kids, full-term normal delivery. Past history, she had chikungunya in the past. Her mother was hypertensive. Thirstless, sleeps on right side. She was thermally hot. Desire salt 3+ or 2+. Sweets, aversion 2+. Brittle nails. She was quite obese, 83 kg, scanty perspiration. She had irritability. You can see it is 12.46. So first she was given lachesis. Next, she did not have early menses for 2 cycles. That is, her menses, the length of the cycle, it became long. The length became more, and it was once in 28 to 30 days. Then again, menses became 3 days early. In February, when we checked, it was 6.3. And in June, it became 0.1. Then she was advised to take less thyroid hormone because it has come below normal. Normal is 0.3 to 5.5. Here it has come to 0.1. So we reduced it to 112. We cannot ask her to stop taking medication because she's on medication from past 7 years and body is dependent on it. Okay, so we can only reduce. We have to taper. So we started tapering. It's we tapered it to from 125 to 112.5. Slowly we tapered. See, here there is lachesis. You can see it is 0.1 in June. Next, case number 5. Patient named Miss DS, age 16 years, presented with the complaints of irregular and prolonged menses since menarche. This is a typical case where the hypothyroidism has affected her menstrual cycles. It was like if she started to have menses, it would not stop, or she would not at all get. Okay, she did not have polycystic ovaries. That was also checked. But this was the symptom of hypothyroidism. We will see later. She also complained of increased eructation and general weakness, aggravation afternoon, tingling in the left hand, dryness of face, throat, and lips, excessive hair fall. The cycles were irregular. Cycles were irregular, once in 40 to 45 days, or maybe sometimes even prolonged. More the length of the cycle, she had bleeding for more number of days. That is, if it crossed 60 days, she would have bleeding for 15-20 days, like that. Usually general duration was 12 to 15 days. Flow was moderate, around 2 pads per day. Character of discharge, dark and clotted. She had scanty muddy white discharge per vagina on and off. She suffered from amoebiasis in childhood, and she was recently detected with hypothyroidism with TSH levels 57.18 micro international units per ml. Her mother is also hypothyroid, known hypothyroid, and she is on hormones. She's totally thirsty. She'll not at all feel like drinking water. She's chilly, desire sweet, desire salt, garlic 3+. This was quite a very, what do you say, striking garlic, because she used to crave for raw garlic. Whatever food, usually at home, they were not eating garlic, but she used to crave for raw garlic. She used to get it and eat it with food. Stools hard and constipated. She sleeps more, that is quite common, and perspiration is absent. She had constant dullness of mind, where you can see the repertory sheet. Pathologist expert system says Nux mosquita, because he was totally thirstless and the symptoms supported. See, it is 57. These are the following details. We had given her the consecutive doses of Nux mosquita, 200, 1m, 10m, 1 dose, that is every day in the morning. After that, no repetition of the remedy. Her cycles came after 2 months, but flow was only for 8 days. It was less clotted, sleepiness was better. Dullness was also better, dullness of mind. Then in October, when we checked, it came from 50 to 6.7 TSH. Okay. Then she had started having regular menses. She also started feeling better. In April, it was 5.6, which was within normal. You can see the reports. So here, we can have various types of prescription with classical homeopathy, like based on totality, based on keynote, based on peculiarity, based on essence of the remedy, and based on pathology. See, you remember all the 5 cases. So the case which I told about the dancer, it was basically the prescription, even though the repertory chart did not show the remedy, the prescription was based on the essence of the remedy. He was staphysagria, he was feministic, anger suppressed, what suppressed, his total, the essence of the remedy, essence of staphysagria was matching him. That is why he became better. And in the last case, 5th case, it was on keynote. She was completely thirstless. Nux mosquita is completely thirstless. We can see Allen's keynotes. You can read that even though the tongue sticks to the palate, the patient will not feel like having water. See, so the Nux mosquita is so thirstless. There is so much dryness of mouth that saliva becomes like cotton wool, and tongue sticks to the palate. Even then, the patient is thirstless, will not feel like drinking water. That is a keynote of Nux mosquita. So she was given Nux mosquita, and first was based on totality of symptoms. The first case, and the case with the lady who had cramps, and who, even though her this one was what do you say, even though she was on thyroid hormones, that case was prescribed on pathology, okay, which may match the Lacaze's pathology. So this is how we can discuss, we can have different approaches with prescription with classical homeopathy in treating all cases, not only hypothyroidism, in treating all kinds of cases. So we should, as there is a saying, what mind does not have, eyes does not see. So we should know the essence, we should know the pathology, we should know the keynotes. So all these, should know the peculiarity. So all these types of prescription, that is, we can say that while prescribing homeopathic medicines, there is no restriction. Okay, we can prescribe based on any of these. Main intention is wellness of the patient and betterment of the patient. So here I end my presentation. Thank you so much. I'm greatly honored to present in front of all very experienced homeopathic doctors who are here. I'm very much thankful to all of you because you joined the meetings. Thank you all.
Hello.
Hello, sir. Tell me, sir. You're audible.
Okay. Doctor, your presentation is nice.
Thank you, sir. Thank you very much.
But I want to know, how will you treat anti-TPO cases? You have not shown any anti-TPO case.
Anti-TBM cases are, they cannot be treated, sir. That is where our scope ends because there is autoimmunity. In all these cases, antibodies were checked. They were negative. That is why we were able to treat. Anti-TGB and anti-TPO cases, that is what I told, thyroperoxidase. There is anti-thyroperoxidase antibodies or anti-thyroglobulin antibodies in the blood. You can only, treat the symptoms. We can only make them better by symptoms. But the thyroid levels, they have to take hormones whole of their life. That is what I feel in my practice. I feel there is limitation.
For anti-TPO case.
Yes. Autoimmune thyroiditis, they have to take hormones.
Doctor, usually we are seeing certain hereditary thyroid cases. We are seeing anti-TPO.
Yes, sir.
And
Yes.
I like to know. Any intercurrent remedy during the course of treatment, if we give may get some good result. I think it's so.
Okay, sir. I'll take your suggestion. But in my clinical practice, I've seen that only when when the symptoms come up, we give the medicine. So in most of the cases with anti-TPO, anti-TGB, we couldn't help because of autoimmunity. We make it a point to check anti-TPO, anti-TGB. Usually, as you told, sir, when there is hereditary, we make it a point to check it. Maybe it would help. I'll take your suggestion from now on, sir. I'll try to give an intercurrent remedy based on past history. Maybe it would help. I'll take your suggestion.
See, in 10 cases, I got the result by medorinum in 3 cases.
Okay.
Medorinum intercurrently, I gave the medorinum 10 1 dose intercurrently. I got only limited result. Okay. But it shows it can be treated. It shows it can be treated, but we are not getting the result. So lack of knowledge.
Yes,
see,
sir.
We are not
getting that is also
that.
Yes. Of course, I agree with you.
In homeopathy, there is medicine.
Yes,
medicine.
Sir.
I think it's so. Medicine.
That is what. Maybe there is a limitation to our knowledge, not to the system.
Not the system. Due to the limitation of our system. Okay,
yes,
doctor, your class is very nice. Come again with another subject. Okay, thank you.
Yes, sir, definitely. Thank you, sir. Thank you very much.
Classical approach. That is
yes,
cool.
Sir.
Yes, sir.
Approach. Yes, sir. Thank you.
We want always classical approach, no tips.
Yes, sir. Thank you. Thank you very much.
Okay.
Any others who have questions?
See, doctor, how is your experience regarding goiter? We can
goiter. That is what, sir. Now there is no endemic goiter. Actually, the cases are very, very rare because of iodinization of salt. It has become very less. Now usually we say actually nowadays we see mostly subclinical hypothyroidism. It's like TSH, T3, T4 are normal, but TSH is more. And most of the cases, more than 40% of the cases are autoimmune thyroiditis.
Okay.
Yes.
See, functions is normal, but the nodules is happening to that thyroid gland, enlarged nodules. What is your protocol to treat such cases?
Again, that is what, sir. Any of the approach of the types of prescription, we'll take the detailed case, we'll repertorize, and of course, finally, the materia medica should match. Only then we can give the remedy. Then we have to keep on checking the thyroid once in 3 months.
What happened, Dr. Hubert? You are not narrating anything.
Sir, he actually is on mute. I think somebody should unmute him. Sir, sir is on mute. That is what he's put in the chat box.
Okay. See, somebody has raised the hand. Jacob
Yes,
Matthew,
sir.
Dr. Jacob Matthew, see, raised the hand. But they are all muted. Dr. Ganesh.
Hi,
Hello,
Dr.
sir.
Deepthi.
Hello, sir. Good evening.
Good morning. This is morning
Good
for
morning. Okay, sir. Good morning.
me. So I would like to congratulate you because you are
Thank you,
taking
sir.
all the very systematically. Your case analysis is superb
Thank you, sir.
and your findings are very fine. I would like to add one thing. Most of the hypothyroidism cases, in most of the cases, about 30 or 40% cases, that should be also connected with those hypothyroidism cases are connected with some other autoimmune diseases.
Exactly.
Especially, I have few cases. One patient had this hypothyroidism, vitiligo,
Yes, sir.
and the Crohn's together.
Yes.
Three
Yes.
of them together.
Yes.
And
Yes.
another case, I have IBS, hypothyroidism,
Yes, sir.
and some anxiety disorders.
Yes, sir.
And in another case, I have a patient with cyst, tumors, hypothyroidism, and something else. In
Yes,
most
sir.
of the cases, these hypothyroidism cases are so complicated. So we need
Yes, sir.
we need to repertorize in a systematic way. We need to treat the patient in a systematic way. We need
Yes,
to
sir.
balance all these complaints together.
Yes,
Only
sir.
homeopathy can do that.
Yes,
Nobody
sir.
else can do
Definitely.
that.
Definitely. Yes, sir.
So my question is, do you have any experience with the TGC, thyroglossal cyst? I have a patient with thyroglossal cyst. I was treating that patient for the last 3-4 years.
Yes, sir.
This patient had some psychiatric complaints, and by repertorization, I found the best medicine was Natromol. The
Yes,
patient
sir.
is the psychiatric complaints was under control, and
Yes,
he's
sir.
perfectly okay right now. And she had some kind of migraine that also was cured, and hypothyroidism, thyroid level, TSH level is normal. But the problem is that the cyst is still like that. Anybody have any experience with thyroglossal cyst? Just let me know. And
Yes, sir.
and second question, just I'm going to stop right now.
Yes, sir.
Second
Yes, sir.
question,
No problem.
anybody have any experience with Helonia's Q? Just like a curiosity, I just want to know that. Anybody has
Sorry,
any
sir.
experience?
Can you please repeat, sir?
Anybody
Helonius.
has any experience with
Helonious.
Helonia's?
Okay. Helonious
Q?
mother tincture.
Yeah.
Okay. Actually, I'm sorry, sir. I don't have experience with both of them, neither with thyroglossal cyst, not with Helonious Q. If
Okay.
any senior homeopaths who have
Yeah.
any idea, please they can share their experience with us here,
Okay.
so that all of us can have a learning arena.
Okay. That's all, Dr. Deepthi. Thanks a lot. Congratulations again. Bye.
Thank you, sir. Thank you so much.
Good evening, doctor. Your session
Good
was
evening.
great.
Thank you. Thank you very much. Thank you very much.
Doctor, I would like to know, after your prescription, after how long does you repeat your TFT?
Once in 3 months, ma'am. Once in 3
Once.
months.
Okay, once in 3 months. And
Yes,
also, you told that in hyper case, there is always a chance for the epiphyseal closure and for the weight height to be standard. And
Yes.
this occurs in hypo also?
No. Actually, ma'am, in hypothyroidism, see, usually if it is in the growing stage, of course it will have stunted growth. Because there is no thyroid hormone. Because of thyroid hormone, there is lack of growth. But in hyperthyroidism, what happens? The bone will grow before age.
Okay.
That is, the bone growth at 14 will be at 10. So there is early closure of epiphyseal plates. That is why there is stunted growth. In both hypo and hyper, there will be stunted growth in growing age. Because in case of hypo, there is no hormone. In case of hyper, everything happens very early. There is stunted growth. Hello, ma'am, you're there? Hello? Hello? Hello.
Hello.
Hello, sir. Good evening, sir.
Madam,
Good evening.
Madam, good evening.
Good evening, sir.
Madam, I have got a patient last week. His
Okay,
main symptoms are dry skin,
sir.
itching
Yes,
all
sir.
over the body, and
Yes, sir.
no thirst, no sweating,
Okay, sir.
hair falling.
Yes, sir.
On blood test, the thyroid hormone levels are normal.
Okay, sir.
Scanning thyroid is on scanning thyroid level is normal.
Yes,
He
sir.
says only the family history. He has family history. His mother only have the same symptoms, and
Yes, sir.
main complaint is constipation, and he is
Yes, sir.
now in potency, etc.
Yes, sir. Yes, sir.
What medicine we can think?
Sir, it's mainly on symptoms. First of all, I practically I tell you to change the lab once and check his reports again. Maybe there may be lab errors. See, yes, that is also there because there may be lab errors, artifacts. The lab reports depends mainly on two things. First is knowledge of the person who is doing it. Second is the quality of machinery and also quality of the reagents they use. So you get it done in a better lab. The reports again once again.
Any other test we can suggest?
You can go for a complete hemogram.
Blood test and scanning only.
No, sir. You can just check his blood, like for complete hemogram and thyroid hormones. That is thyroid profile T3, T4, TSH.
Okay.
Maybe you can change the lab and get it done once more. Get it done in a better lab in a bigger place, or maybe a reputed lab, which has better equipment, better staff. Maybe you can cross check.
Okay.
Even then, if it is normal, then you can treat him symptomatically.
Okay. Which of the medicines we can suggest?
Dryness of skin, there are so many remedies, sir. We can think of what do you say? All skin remedies like petroleum. There are so many remedies. It depends on the case. No, sir. We have to repertorize the symptoms. Then we have to match the materia medica. Only we can prescribe.
His main symptoms are constipation, dryness of skin, itching all over the body.
Okay, constipation and constipation. There are so many remedies like lycopodium, calcarea carb. There is Nux vomica, again Nux moscata. See, most of the symptoms when you are saying it matches Nux moscata, like you can think of. I'm just suggesting only after repertorization and seeing the symptoms. Only then we can prescribe. Like dryness of skin, scanty sweat. You can think of Nux moscata. It's only a suggestion.
Okay.
Okay.
Thank you, madam. Thank you.
Thank you,
Come
sir.
again.
Thank you so much.
Come again.
Yes, sir. Definitely.
Okay.
Thank you, sir.
Okay.
Doctor, most of the case,
Yes, sir.
constipation with the skin symptoms.
Yes,
Only
sir.
it is a tip that I'm like, constipation with the skin symptoms. Graphite
Yes, sir.
is the best remedy.
Yes, sir. You can also, yes, sir. Of course. Graphitis can also be thought of.
Okay.
Sir, I will interrupt here. Whatever symptoms, we are discussing, no, sir, that like dry skin, constipation. See, these are common symptoms of hypothyroidism, sir. The one who is suffering with hypothyroidism, these are common symptoms. So when we are treating the patient classically, so the common symptoms will have very less value and uncommon symptom will have more value. Definitely. It is when it is common to the pathology, right? The one who has a hypothyroid disorder, dry skin, usually what happens when the patient comes with a history of hair fall or dry skin, if we check the thyroid levels, there will be a fluctuation in the thyroid levels.
This is why you just once change the lab and check it once again, sir.
Okay.
Yes, now it is for Dr. Sunil to say, ask a question. Dr. Sunil.
Hello, sir. Good evening. Namaste.
Good evening. Dr. Sunil, now you can unmute yourself and speak. Dr. Krishnamurthy, please ask Dr. Sunil to unmute.
Yes, ma'am. Good evening.
Okay, okay.
Good evening, sir. Good evening. Namaste.
Ma'am, it was a very nice presentation.
Thank
So
you, sir. Thank you
usually,
very much.
I would like to ask one thing.
Yes,
Usually,
sir.
patient will be on L-Troxin and all. So
Yes,
what
sir.
is your protocol in tapering?
That is what, sir. That is what I told you in the last case. In the fourth case, when the thyroid, when the TSH levels became below normal, that is 0.1, it came to 0.1. Then we tapered it by decreasing the dose to 112.5 from 125. That is how we taper, sir. Even that is what. See, once we taper, again we check it once in 3 months. Okay. Even after 3 months, again, if it is below normal, if TSH is below normal, we can also see that T3, T4 levels will be on the higher end. Okay, nearing the higher end of the value. Then what we do, again, we reduce it by 12.5. That is, we'll come to 100. That is how we'll reduce. Hello? Hope it was clear, sir.
Hello, ma'am, is it audible?
Yes, sir. Yes, sir. You're audible. Tell me, sir.
Yeah, actually, it was a very wonderful presentation from your side.
Thank you, sir. Thank you very much.
I really congratulate you
Thank you, sir.
for your skill in managing thyroid diseases.
Thank you, sir.
Especially your prescriptions, a variety of methodology you have used in your prescription. I really congratulate.
Thank you, sir.
Particularly the prescription based on the essence of the remedy. That is
Yes, sir.
really wonderful.
Thank you, sir.
Homeopaths
Thank you.
should always should have a thorough knowledge about the essence of the remedy. And moreover, my suggestion to concentrate more on the TPO and AM and
Yes,
ATG
sir.
antibody cases.
Yes,
So
sir.
in homeopathy, we can do wonders in Hashimoto thyroiditis and Graves diseases.
Yes, sir.
And one query regarding the thyroglossal cyst. Yeah, actually, it is manageable in homeopathy using various drugs like Silesia, Natramur, etc. Based
Yes.
on totality itself, we can manage thyroglossal cyst. And regarding a remedy, my suggestion of Helonius. Helonius is a wonderful remedy for managing this glycosuria as well as diabetes, especially of pregnancy origin. It is a wonderful remedy.
Dr.
Okay.
Ravish,
Yeah.
as the time is running out, you may please say vote of thanks also, because already
Okay, ma'am.
and we will have
So,
another. We can have another
on behalf of International Forum for Promoting Homeopathy, we are so much thankful to Dr. Deepthi Anand for her
Thank you,
wonderful
sir.
presentation.
Thank you very much.
Presentation.
Thank you. I'm
ma'am.
humbled and honored. Thank you very much. And I try to come back soon again with some other topic.
Definitely.
Sure,
we are,
sir. Sure. Always welcome.
Thank you, sir. Thank you very much. Thank you.
We are very happy to have such a nice person presenting one more paper. We are always welcome, and you are
Thank you,
always
sir.
on stage.
Even I am honored. I'll be very much happy to present again. I'm very thankful to everybody for giving me this opportunity. I thank the International Forum for Promoting Homeopathy for providing me this. And I also thank all the doctors who have joined and patiently listened to whatever I told. If there are any mistakes, the senior homeopaths, please forgive and please try to correct. And thank you very much. Thank you, one and all.
With that, we come to the end of the session, and now it is the time for our Malayalam session.